afternoon, everybody. I think as the time is up, we will start the lecture. We hope that there will be more of a crowd joining us, towards as we proceed. So it is this therapeutic update lecture series is organized by the Sri Lanka Medical Association Medicinal Drugs Committee. So we regularly have, like once in 2 months, medicines updates. So today actually we are having a symposium. Normally it's a 1-hour lecture, but here we have decided to have a symposium on iron deficiency anemia, where 3 experts will be covering the topic about iron deficiency anemia in 3 situations, in adults and in pregnancy and in children. So it is my pleasure actually to introduce, I think we will introduce one by one before they start. So first to introduce Dr. Anaemia, who is a consultant physician now at the National Hospital of Sri Lanka, to start the symposium by talking on anemia in adults. Over to you, sir.
Ladies and gentlemen, one of my favorite pastimes is to go to a drinking party and listen to people who start their philosophical discussions after losing their brains. And recently I was listening to one of my friends who said, "Macha, issek dila nipudune kiyana hari santosai." Thinking about this further, unlike the vertebrates, ladies and gentlemen, who have hemoglobin, some mollusks and arthropods have hemocyanin to carry oxygen in blood. Hemocyanin is copper-based and hemoglobin is iron-based. Copper is 0.0068% of the Earth's crust, whereas iron is 6.3%. And despite this abundance of iron, 2 billion people in the world suffer from iron deficiency anemia. You should be happy, and I am happy that I am not a mollusk. The males have about 3.5 grams of elemental iron in their body, and the females 2.4. And out of this iron you can make 3 small paper clips. And most of this iron is in hemoglobin in red cells and the rest in storage proteins. We absorb about 1 to 2 milligrams of iron through the gut, mainly the ferrous form. And this is carried in plasma in ferric flow inside transferrin molecule to the tissues to make hemoglobin, myoglobin and iron containing enzymes. Rest of that is stored in macrophages and hepatocytes, mainly as ferritin and hemosiderin. Like any other commodity, iron is also subjected to market forces, the supply, the demand and the loss. So demand for iron is high in the formative years, the childhood, adolescence and in pregnancy. During the pregnancy, the fetus needs about 280 milligrams of iron, whereas the temporary expansion of maternal red cell mass demands another 400 to 500 milligrams of iron. And at the delivery, the mother loses about 200 milligrams of iron through blood and placenta. And sometimes the demand for iron cannot be met with supply because of poor intake, the poor absorption and sometimes due to drugs. Sometimes the loss of iron through the menstrual bleeding, through the gastrointestinal tract and through blood donations make it deficient. the fact that the demand for iron is high in childhood, adolescence and pregnancy and in menstruating people, deficiency of iron is not worth the extensive diagnostic workup. You treat them with iron and worm treatment and investigate only if the patient does not respond to iron. When you take a meal, most of its iron is in the cereals, in the ferric form, which will be liquefied through the change to ferrous form by the cytochromes in the rush border to be absorbed through the divalent metallic transport protein. Therefore, only up to 0 to 20% of non-heme iron ingested is absorbed to the enterocyte in duodenum. The iron in the heme molecule, which is present in fish and meat, is directly transported through the heme carrier protein into the enterocyte. And both the heme and non-heme iron now goes into the labile pool inside the enterocyte, and this has to go through to the plasma, through the serosol membrane, through a carrier protein called ferroportin. If not, the enterocyte will shed into the intestine, the iron inside will be lost to the body, and it will be a loss. A molecule called hepcidin produced in the liver destroys the transport protein, the ferroportin, stopping the iron absorption. Not only that, it will stop the macrophages releasing iron for the hemopoiesis. The hepcidin molecule is produced during iron overload and inflammatory conditions, and is cleared through the kidney. And more of this later. When the battery is running low, can somebody look at the computer? And when the iron becomes, the demand for the iron outpaces the supply, first the iron stores will be depleted. Thereafter, the erythropoiesis will be iron deficient, and ultimately iron deficiency anemia occurs. During the depletion of iron stores, the iron absorption is increased and the serum iron will be normal. However, the stores, the serum ferritin will be low. When there is further iron depletion, iron deficient erythropoiesis occurs. At this stage, the serum ferritin level drops below 15 micrograms and the transferrin saturation drops below 15%. However, the hemoglobin, MCV and MCH will still be within the reference range, although when you treat with iron, there will be a significant rise in these parameters. When the depletion goes further, iron deficiency anemia occurs, resulting in microcytosis, hypochromasia and poikilocytosis. The reticulocyte count will be low compared to the degree of anemia, and the TIBC, serum iron and the transferrin saturation will be lower. If you do a bone marrow, which you don't, the macrophages will show a total absence of iron, and there will be tissue effects of iron deficiency like polyonychia, calcini, angulostomatized glossitis and pharyngeal webs, called the Patterson-Kelly syndrome, partial villus atrophy, and problems in the immunity. The causes for iron deficiency are many, but in the Sri Lankan context, it is bleeding and the poor diet. A blood loss of 6 to 8 ml per day cannot be compensated by dietary iron intake alone. The GI blood loss is commonly due to worm infestation, especially hookworm, But if your patient is at the at-risk age for cancer, worth investigating for bowel cancer. The menstrual blood loss is important, but Professor Kaluara will deal with it. During hemodialysis, about 6 to 8 milligrams of iron will be lost during each cycle. If your patient is not a teenager or not menstruating or not pregnant, think about investigating the patient first with stool focal blood, upper and lower GI endoscopies, capsule endoscopy, but screening for tumor markers like CEA and CA19.9 will be useful, but a negative tumor marker will not exclude the possibility of a colonic cancer. If you are exhausted the other possibilities of, or if your patient gives the history of dark urine early morning, think of paroxysmal nocturnal hemoglobinuria. You may investigate for malabsorption, gluten-induced enteropathy, Helicobacter pylori, and iclohydria, and inflammatory bowel disease. How do you manage iron deficiency anemia? It is twofold. One is to identification and treatment of the underlying cause, then correct the iron deficiency with inorganic iron. The drugs will be dealt with later. It will be sufficient to say that ferrous sulfate is the drug of choice and the dose is 1 tablet 3 times a day. And remember, enteric cotton and sustained release preparations should not be used because much of this iron is released beyond the duodenum, and the duodenum is the main site of absorption. When you treat with oral iron, the minimum rate of response should be 2 grams per every 3 weeks, and it is necessary to treat 3 to 6 months to correct the deficiency of iron in the hemoglobin and in stores until the ferritin is normal. And if your patient fails to respond to oral iron, it is most commonly due to the patient not taking it, or could be due to hemorrhage or malabsorption, and you have to exclude the other causes of microcytic anemia. And a poor response may also be obtained if the patient has an infection, hepatic failure, underlying malignant disease, or anemia, or inflammation. Remember the hepcidin. Parenteral iron is necessary when the oral iron is not tolerated, and when there is gastrointestinal disease or inflammatory bowel disease, because the hepcidin will stop the transport of iron through the basal membrane, and to replenish the body stores rapidly, especially when the iron deficiency anemia is first diagnosed in late pregnancy. And if your patient's iron loss cannot be sufficiently treated with oral iron, as in patients with hereditary hemorrhagic telangiectasia. In patients with chronic renal failure, the iron is not, the oral intake is less because of loss of appetite, and then because of the hepcidin, the iron is not transported through the enterocyte, and the macrophages can't release the iron. And hepcidin is not cleared through the kidney because of kidney failure. So these patients may need parenteral iron. And the calculation of the iron requirement, which I can't remember, is there on the leaflet of your Vinotha. And thank you very much.
Thank you, Dr. For that initial overview on the iron, metabolism of iron and how iron is stored in the body, which will pave the way for the next two presenters to talk about. Next, we have in the agenda an important cause that you highlighted, that is in women. So in women, I think the most common problem that is manifested and which has to be managed properly is anemia in pregnancy. So in order to address that aspect, I would like to invite Professor Atula Kalwarachi, who is a consultant obstetrician and a gynecologist, and a professor in obstetrics and gynecology in the Faculty of Medicine, University of Colombo, to deliver the presentation.
Thank you very much. First of all, let me thank SLMA for inviting to make this presentation. When you talk about anemia in pregnancy, now compared to in a non-pregnant person, the definition of anemia in pregnancy is different. That's the first thing they have to know. If the first trimester, a hemoglobin of 11 is the cutoff for considering a patient who is anemic. If it's above 11, is considered adequate. And when you come to the second trimester, the hemoglobin of 10.5 grams per deciliter is considered normal. We come to the reasons. And when you come to the third trimester as well, it's considered 10.5, and in postpartum first woman, HB of 10 is considered normal. The main reason for considering these values as normal is simply because there are physiological changes in pregnancy which changes the hematological parameters throughout the 4 weeks. Now, we know when you in a pregnant woman, the plasma volume keeps on increasing from the start of the first trimester and peaks around 32 weeks and keeps at that level, and an average increase about 40 to 50% increase in plasma volume occurs in pregnancy. And compared to that, the red cell mass increase is less, about 18 to 20%. So there is a relative hemodilution that occurs throughout the pregnancy, and that is one of the reasons why hemoglobin of less than a non-pregnant person is considered normal in a pregnant woman, because there is an increased changes in the hematological parameters. I'm not going to detail all physiological changes, but these are the two main important things in relation to anemia. Now, if you look at the prevalence of anemia in pregnancy, the WHO estimates, of course, in average for the whole world, you will realize it will be much less in the Europe compared to the African countries. It's average about 40% of women who are pregnant do have iron deficiency anemia, not iron deficiency, anemia, and majority of these cases are iron deficiency. And in Sri Lanka, there are various studies that have done, and the studies ranges about 1/3 of our women are anemic during pregnancy. Now, it is important to realize, as the previous speaker spoke to you, the HP, hemoglobin level, does not mean always the iron stores are normal, and it is very important to have normal iron stores as well, because it's for cellular function, the iron is important, so that people can have symptoms like lethargy and other symptoms. Even it's important for your neuro development. So they can have symptoms due to iron deficiency, and the ferritin levels are considered differently. Some of the studies have considered below 12 and some have considered below 30 as iron deficient. So this is something that is important. And out of the people who are anemic, they say 30% are anemic, but good thing is most have mild form of anemia. That's the point. So if you take the anemia, we said about 30%, after about 20% of that 30% is you have mild anemia, and we consider mild anemia from about 9 to 10.9 or 11 grams per deciliter is considered mild. And moderate is considered 7 to 8.9 or rather 7 to 9, and severe anemia is considered from 4 to 7. Right, so severe anemia is not common, but it's rare. Mostly are mild to moderate anemia. And even our other studies also, the several studies, even here you find mild anemia is also 20%, but moderate to severe also was 13%. Now, as it was mentioned earlier, the commonest reason for anemia, of course, could be physiological because of the hemodilution. Sometimes you can have mild form of anemia simply and during the period gestation. As I told you earlier, because of the increased plasma volume is higher in relation to the increase in residual mass. But if you take the real reasons other than the physiological change, the iron deficiency is the commonest form of anemia, followed by folic acid deficiency in pregnancy, and B12 deficiency is there. And there are other reasons for people to be anemic. Another important one, of course, I'm not going to deal in length, of course, to realize even things like hemoglobinopathies are seen in pregnancy. Now, why do women have iron deficiency anemia as the commonest cause? One, the first thing is to realize most of these studies done even in the first trimester of pregnancy shows that about 20 to 25% of women start their pregnancy with iron deficiency. So they start with a negative balance, and of course the other reason is if you have pregnancies with a shorter inter-pregnancy interval, you have already lost iron in a previous pregnancy, you get pregnant within another 6 months or so, and you are starting with a much more negative balance. So that's one of the reasons the short pregnancy interval could lead to iron deficiency. And in adults, as it was mentioned earlier, about 1 milligram per day iron is lost for various functions. And if you take to compensate for your menstruation in a female, it's calculated at least about 0.8 milligrams per day. So that your iron requirement in a female would be about 2 milligrams per day, considering your normal loss as well as the loss at menstruation. The iron requirement for a pregnant woman changes throughout pregnancy. What is required in the first trimester? Basically, if you look at the iron requirement, it is for the fetus, it's for the placenta, and it's for the fetal growth. The iron is required. And also, in the latter part of pregnancy, iron is required to store in the fetal liver, because immediate newborn needs iron as well. So when you come to the first trimester, I said it's about 2 milligrams, and when you come to second trimester, your demand increased to about 4 to 5 milligrams due to increased red cell mass production as well as the placenta requirement and the fetal requirement. And when it comes to third trimester, your requirement of iron is about 6 milligrams per day. And as mentioned earlier, when you have the delivery, you lose about 250 milligrams of iron. If you look at that, the requirement, if you start with start from here, with the advance in pregnancy, then there's a normal turnover. You increase your requirement for your increase in red cell mass, and the fetal requirement also is in purple, gradually increases throughout pregnancy, and it gets the highest in the third trimester. And here, not only the fetus and the placenta, there is active transfer of iron to the fetus in the last 4 weeks of pregnancy, so that the fetal iron stores are built up during pregnancy, the last 4 weeks. That's why in the preterm you have more problems with anemia and things like that if the baby is born early. Now, what are the risks to the mother and the fetus when there is iron deficiency? There is good data to suggest that if you are iron deficient, if you are anemic, I mean people are not really classified as iron deficient in some of these studies, but as we know, it's the commonest reason. Your risk of dying, the maternal death, is high in people who have anemia. Of course, the other problems comes. You need more blood transfusion, and people have higher risk of antenatal and postnatal sepsis if you are anemic. Your risk of preterm birth is higher in patients who are anemic, and it is shown that requirement for the intensive neonatal care is higher in women who deliver with a low hemoglobin. And so also it's interesting to see, although there are these data, there's good evidence that's coming up to suggest that if the mother is anemic and if the mother is iron deficient, the fetal development can get affected. So there is, with decreasing hippocampal volume and long-term neural development could get affected in babies born to women who are anemic and especially iron deficiency. And it is also observed that people who are iron deficient deliver babies with less birth weight. As I mentioned to you earlier, iron transport to the fetus mainly occurs in the last 4 weeks of pregnancy, and if the mother has iron deficiency and the mother has low iron stores, of course you will realize obviously the newborn will have a depleted iron stores, and it is shown that babies born to mothers with iron deficiency have a high risk of anemia in the first year of life. And this is something that is coming up. Whether, you see, we know that growth restricted babies do have a higher risk of hypertension in later in life. Hypertension, diabetes is higher in babies born with a low birth weight. Similarly, there are observations that if the mother is anemic, you tend to have a larger placenta, and placenta fetal ratio becomes high, and that seems to have an impact on development long-term hypertension in later life. That is not 100% proven, but there is evidence that is coming up about these associations. Now, so because of this, it's very important for us to realize that iron deficiency is an important thing. Now, in a pregnant woman, because of these increased requirements, it is recommended that you have iron supplementation. Now, iron supplementation, as mentioned earlier, is mostly done with oral iron, and the commonest is ferrous sulfate. We'll come to that later. And what you give to a pregnant woman as iron supplementation, either you can give as a daily dose of iron, or there are people who cannot tolerate iron very well, you can give. There are different regimes that have been studied and shown to be more or less equally effective, giving it iron supplement every other day, or sometimes giving it once a week, especially in people who cannot tolerate this iron taking daily. So those are options that are available for your supplementation. Now when you have iron deficiency, the anemia management will really depend on these factors. Your severity of anemia, of course the mother is symptomatic. Here we are talking about the etiology being iron deficiency. We need to look at the urgency to correct anemia. When you, as mentioned earlier, if you are somebody who's in the first or second trimester, you have time to correct the anemia. You can take a different strategy compared to somebody who's detected to have anemia at 36 weeks, where it is important to correct urgently. Anemia has to be corrected because of the labor and the delivery. Iron deficiency has to be corrected because, as I told you earlier, this is the time that iron is transported to the fetus. So that is also an important consideration. And of course, you need to look at what the long-term management is going to be. Now it is important to realize, now we do have people in severe anemia going hemoglobin going down to 8, 9 and all, but the critical level seems to be 6. If anybody has hemoglobin of less than 6, and that is where especially the fetal oxygenation could get affected, because the oxygen transfer is active, because you need the hemoglobin to transport the oxygen. So if anybody has hemoglobin less than 6, it's urgent that you need correct, because there can be effects that are occurring in the fetus which are not long-term effects, which are short-term problems, like having fetal compromise because of the severe anemia, the fetal hypoxia could develop. So, if you have any of these hemoglobin going down less than 6, it is important that you transfuse. Of course, if the mother is symptomatic, supposing she got not even cardiac failure, if the patient is significantly symptomatic, and obviously if there are any infections or any interference in cardiac status, then you need to transfuse even earlier than that. Now, iron replacement, as I mentioned to you earlier, the prophylactic could be prophylaxis. If the hemoglobin is normal, if your iron stores are satisfactory, you just need to give iron to maintain. And recommended dose is actually about 30 to 60 milligrams of elemental iron per day. Elemental iron per day, which is they are found in about 200 to 300 milligrams of ferrous sulfate. And you have other preparations like ferrous fumarate, which the total capsule dosage may be different, but the target is to give elemental iron 60 milligrams per day. If somebody is anemic or iron deficient, you need to give a therapeutic dose of iron, which is about 120 milligrams of elemental iron per day. And there are, of course, there are various studies done and various theories that are being built up, whether we should sort of change the dosage depending on the serum ferritin levels. When somebody has got serum low ferritin level, do they need a higher dose of elemental iron? As I mentioned to you earlier, different regimes are there to supplement, either giving it every day, especially they can tolerate, but otherwise you can give it every other day or even once a week. Now, this is crowded, but don't worry about it. There are just to mention that there are several oral iron preparations that are there. The ferrous sulfate is perhaps the most commonly used preparation, because it's easily absorbable and its availability is high with ferrous sulfate. You have ferrous fumarate, ferrous gluconate, and of course various polysaccharide ion complexes are available as oral preparations to be used. As mentioned earlier, the coated tablets where they claim it's released in the duodenum or something like that, the layer released in lower part of the gut is not really recommended to be used in pregnancy. Now, if you look at the different and other option is of course giving parenteral iron. Certainly, if you give oral iron, it's effective in most patients. Low risk of adverse effects and of course low cost. Where if you give oral, the most problems are it can cause GIT side effects, and the reliability of women taking it, especially if you have second or third pregnancy, how reliable are they taking? Then, of course, you need to continue throughout pregnancy. You can't give it as a single dose. Whereas if you give an intravenous iron supplementation, you can give it as a calculated single dose, or maybe over a period of a couple of days. Of course, it's a less side effects, no GIT side effects. You are assured of compliance. Only thing is, IV, if you are giving it, you can do it in hospital under supervision, and rare problems like allergies and things are there, but they are not so common as sort of sometimes people are worried to give parenteral iron thinking of these reactions, but this doesn't happen so often. Now, as far as a pregnant woman is concerned, we do not use parenteral iron as a routine for obvious reasons. The main indications for parenteral iron is if you are not compliant, if you can't rely on the patients. Sometimes if you use people like Jehovah's Witnesses and people like that, you need to correct things early because you cannot allow them to go to labor with a low hemoglobin because issues. If your iron deficiency is not get corrected with oral iron, and of course if there is a problem with gut because of absorption. And generally it is recommended to avoid any kind of parenteral iron in the first trimester. We do not know exactly, there is no definite data to say it's harmful, but still the safety of parenteral iron in the first trimester is not being established very well. The first trimester being the period of organogenesis, I think it's important that we take care. Again, don't look at this slide. I mean, anybody wants, I can give it. It's there. There are many different types of parenteral iron preparations. I mean, we used to have Venofer earlier. What is the maybe different to but there are so many different types of parenteral iron, and their dosage regimes are different, and whether they can be given, and most of these parenteral iron you cannot give it, you have to calculate the dose, but you will not be able to give the total calculation just over a single day. Depending on the preparation, you need to decide how much maximum dose of parenteral iron you can give per day. Sometimes combination with erythropoietin is being done if there is an indication to do so. So that is where actually that covers the iron deficiency part. I don't think I thought it was iron anemia in pregnancy and just did a few slides on hemoglobin because that is the other important one that is relevant to pregnancy. I just quickly glance through the main implications of the thalassemia that we see commonly. I mean, we don't see people who are thalassemia getting pregnant. They are, of course, not, they are iron deficient, they are iron overloaded. As you know, they have problem of fertility as well. But if they get pregnant, the main issues are the ones that are listed on the right side. Okay, the thrombotic effect, need for transfusion, risk of infections. Because of the pancreatic function and pancreatic effect, they can have any of the other medical problems coming. Common one we see is the minor or thalassemia traits. Generally, they are not a problem. Only thing we do usually do the serum ferritin levels, and that if the ferritins are low, about less than about 30, then you can think of still giving oral iron supplementation. Of course, these patients better to avoid parenteral iron supplementation. Okay. That's okay. You don't see this in our country, so I don't think it's very relevant. Although I was trying to do it, I can skip that for the time factor. This is something that perhaps we'd like to know is the importance of prenatal testing in people who are even thalassemics. Right? So you can screen them antenatally to see whether the baby is affected or not, especially using at about 8 to 10 to 12 weeks you can do a chorionucleus sampling. Or now we have, although this is not very well established, you can take a non-invasive prenatal testing after about 10 to 14 weeks, especially this is used for screening Down syndrome and other aneuploidies. But this is being tried to, they are sort of trying to use this to screen the hemoglobinopathies as well. And the other way that you can screen, of course, in IVF, before implantation of putting an embryo back into the uterus, you could screen for any kind of abnormality. Thank you very much.
Thank you very much, Professor Kayarachi, for that nice overview, which has set the stage for the next presenter, because he was talking about the problems in pregnancy leading to anemia in children. So we will take questions at the end of all three presentations. And I would like to now invite Dr. Sachin Prithananda, who is a consultant pediatrician and a senior lecturer in the Department of Pediatrics in the University of Kelaniya, to do his presentation on anemia in children.
Good afternoon. Thank you very much, madam, for inviting me for the lecture today. And as we all know, children are not small adults, so whatever the things said during the past two lectures may be slightly relevant, but most of them are quite relevant when you come to pediatric practice. It's a very common scenario for us who are seeing patients in the pediatric age group to see babies coming with sort of viral illnesses, and because of these dengue epidemics, they are quite commonly, they will undergo full blood counts, and the full blood count will give different hemoglobin value. So we take an 11-month-old boy who is coming with a viral illness. Normal clinical examination, hemoglobin is 10.5. People who are doing in general practice, it's a very common scenario. So, is this normal, abnormal? What should we do? Is it normal for this age? That's a very common question we all encounter. What do you think? Normal or abnormal? Some might say it's normal. Some may say not, because it's still controversial. Although the anemia is one of the most common problems that we encounter in global health, definition of anemia in children is still controversial. However, for the time being, we are WHO cutoff values and definitions, which says in children between 6 months to 5 years, hemoglobin less than 11 is considered as anemia. In children above 5, hemoglobin less than 11.5 is considered as anemia. With these cutoffs, the prevalence of anemia in Sri Lanka is approximately 15%. It's quite high. So we know the cutoff values for babies who are above 6 months and what's the scenario in babies who are less than 6 months. There are no cutoff values because the hemoglobin has a physiological change during first 6 months, which is demonstrated in this graph. Concentrate only the graph here, which shows the hemoglobin and -2 standard deviations. As you can see, the babies who are born at term have a hemoglobin of approximately 15 to 24 grams with a mean of roughly close to 20 grams. But this hemoglobin will drastically drop during the next 2 months due to several reasons. Firstly, in utero, the fetus is in an oxygen deprived environment. After birth, you get plenty of oxygen, so you are not in a hypoxic situation. Secondly, you have a physiological transition from hemoglobin F to hemoglobin A, which is a hemoglobin molecule which releases oxygen quite easily. Due to these two reasons, the baby will not need much of hemoglobin. So the hemoglobin will drop because of the hemolysis to a lower level as low as 9 grams per deciliter. And the lowest value is reported around 6 weeks to 8 weeks. So if a baby comes with a hemoglobin of 9 at 2 months, if the red cell indices are normal, I'm not worried. That's a physiological anemia of infancy, which will, then the erythropoietin will start producing and the hemoglobin will gradually go up to reach 11 grams per deciliter at 6 months. So coming back to the case, for the patient, 11-month-old child has hemoglobin of 10.5. All the full blood count reports will give you red cell indices, and the NCV is 67, NCH is 53. So 29. As we know, anemia can be classified based on red cell indices into microcytic, normocytic and macrocytic. The cutoff value for microcytosis in children is somewhere between 70 and 80. But you know MCV of 67 is low. So this child has microcytic anemia. The most likely diagnosis for microcytic anemia in children or even in adults is iron deficiency anemia. So it's very likely that this child has iron deficiency anemia. As previous speakers have correctly pointed out, iron deficiency is a sort of a spectrum. Initially they will only have iron deficiency with low iron stores with normal hemoglobin, but when it is being continued, you will develop iron deficiency anemia. What are the risk factors for iron deficiency in children? Iron deficiency is extremely rare between 0 to 6 months, unless there is maternal iron deficiency or prematurity, because the iron transfers during the trimester. If the baby is delivered at 28 weeks, they will have very low iron stores, or unless there is any sort of perinatal hemorrhage. So we don't see babies below 6 months having iron deficiency. But it's extremely common in later infancy as well as during the first few years of life. And the most important cause for iron deficiency in children is insufficient dietary intake. Similarly, occult blood loss may be a cause. For example, Becker's diverticular hemangiomas, rarely inflammatory bowel disease, or hookworm infestations or infections, which are extremely rare now in Sri Lanka. During adolescence, it may be due to menstrual blood loss. But the other secondary causes like tumors and those things are not common in children. We don't consider them in the differential diagnosis if someone comes with iron deficiency. What are the clinical features? 99% of them will be asymptomatic. So this will be picked up or detected incidentally. The only sort of important clinical feature would be pallor if they have iron deficiency anemia. Again, will not be evident if the hemoglobin is something like 8 or 9, unless it is less than 7. Iron deficiency can sometimes lead to pica, that means eating of non-nutrient substances, pus kanwa, hal kanwa, different things, right? That's quite common in children. That's because of iron deficiency, or they might ingest sort of desiring SIs. When it is severe, you develop anemia and you have all the features of anemia which are common to any sort of anemia. In pediatric practice, they are different to adults: irritability, anorexia, bit of lethargy. When it is severe, there will be cardiovascular compromise with tachycardia, flow murmurs, and if you don't intervene, will end up in cardiac failure. So you suspect iron deficiency anemia because there is microcytic hypochromic anemia. So how are we going to make the diagnosis? Again, this is one of the most common public health problems, but still we don't have a gold standard diagnostic tool. There's no way that we can conclusively diagnose iron deficiency in every child. The most commonly used one is serum ferritin, as we all know, which is quite widely available. Serum ferritin less than 12 or 15, depending on the age, is considered as iron deficiency. However, serum ferritin is an inflammatory marker which can go up drastically in infection or inflammation. Sometimes in the bacterial infection, it can be even thousands. In conditions like idiopathic arthritis, it can be 5,000. So it's a acute phase protein. So you need to make sure that there is no inflammation or infection to interpret serum ferritin. Serum iron profile, on the other hand, is less likely to be affected by inflammation, but it's not very widely available. If you want to do, we do serum iron, total iron binding capacity, and transferrin saturation. In iron deficiency anemia, serum iron will be low, iron binding capacity or transferrin will be high, transferrin saturation will be less than 16%. But in clinical practice, we generally tend to rely on serum ferritin. There are certain other investigations which are basically in research. One is erythrocyte zinc photoporphyrin, which will be increased in iron deficiency. Soluble transferrin receptor, again, will be increased in iron deficiency. And the most recent one, which is still being optimized, is serum hepcidin, which will be decreased in iron deficiency. So the diagnosis is possible, but have its own pros and cons. To make the diagnosis of iron deficiency when the serum ferritin is less than 12 in 6 months to 5 years, so less than 15, in the absence of inflammation. Sometimes, especially in children less than 2 years, we believe most of the most likely cause for anemia in this group is iron deficiency. So there is a place for an empirical trial of iron, the treatment dose of iron, to give it for 1 week, 1 month, that is for 4 weeks, and to demonstrate a response. So response to a therapeutic trial of iron is again considered as a marker of indicator of iron deficiency, or to confirm the iron deficiency. You need to demonstrate the rise of hemoglobin by 1 gram per deciliter. So it becomes different to adults. So we only need a rise in hemoglobin 1 gram per deciliter after 4 weeks of appropriate dose of iron. Once confirmed, how are we to treat? Treatment of iron deficiency anemia, we almost always use oral iron because it's very readily absorbed and the response is quite rapid. 3 to 6 milligrams of elemental iron per day. Any ferrous salt, commonly we use ferrous sulfate. Here we have to be a bit careful in pediatric practice. There are syrups, drops, and tablets which are iron containing. And at the same time, you have several multivitamin preparations which are containing iron. But most of the multivitamin preparations will have inadequate amount of iron to treat iron deficiency. So every time you treat a patient with iron deficiency, you need to find out the amount of elemental iron in that preparation. Generally, iron drops will have 50 milligrams of elemental iron in 1 ml, iron syrups 50 milligrams in 5 ml, iron tablet, ferrous sulfate 200 milligram tablet will have 60 milligrams, and there are certain preparations which have 100 milligrams per tablet. Can be given as a single dose or 2 to 3 divided doses. Given between meals, the absorption is highest when it is given 30 minutes before or 2 hours after a meal. If you give it with a juice, it increases absorption. Side effects are minimal. It has an unpleasant taste and bit of gastrointestinal sort of complaints in older children. So that's how you would treat iron deficiency. What about other things? It's quite common for us or doctors to prescribe iron, vitamin C, folic acid, or sometimes antihelminthics together when you see someone having anemia. If it is microcytic anemia, there is no evidence to suggest giving vitamin C or folic acid along with iron to improve the outcome. So it's not necessary. No point giving vitamin C or folic acid if it is iron deficiency. Antihelminthic treatment, probably there's no place in Sri Lanka because hookworm infections are extremely rare now. It's less than 0.1% in most of the places. That's the only word that or trichosis are the ones that will cause iron deficiency. It is not a cause, it will not be a complication of pinworm infestation that we generally have in the country. So antihelminthics are not really needed. Parenteral iron, I have probably used only once. It's very rarely being used. Only in the presence of malabsorption you will be using parenteral iron. Blood transfusions, again very rare unless the patient is in impending cardiac failure. The hemoglobin is very low, maybe 4 or 3, or they are about to go into cardiac failure, or unless there is ongoing blood loss. So the treatment of iron deficiency is very easy. You can do it as an outpatient by oral iron treatment. The other thing, important thing is to advise on diet. Especially in kids, you need to advise them to take iron-rich food. What I tell them is fish, meat, egg yolk, green leaves and pulses. Fish, meat, egg yolk, green leaves and pulses. And you can use some iron fortified food, that's up to them. If you take some vitamin C containing food along with iron containing food, it might increase the absorption. If you take tea or coffee along with the meals, it will decrease the absorption of iron. Just prescribing iron and giving dietary advice is not sufficient. You need to make sure that this child recovers. This child hemoglobin goes up. The easiest way is to repeat the hemoglobin after 1 month. It's iron deficiency, you have to demonstrate 1 gram of deciliter rice. If you are desperate, if you want to see the response early, you can do a reticulocyte count which will be evident within 2 to 4 days. But it's not essential. So you do hemoglobin, and when the hemoglobin is normalized, when it is above 11, you continue iron for another 3 months to make sure the stores are depleted. We generally don't repeat serum creatinine. But if you continue for another 3 months, then that will increase the serum creatinine. Some situations of iron deficiency, you will not see the rise. It will be refracted. So what are the causes? One can be poor compliance, but if you have given the adequate dose and the mother thinks that we have taken, so that's unlikely. So you will need to think about occult blood loss, whether there is any sort of celiac disease, house milk protein intolerance, some sort of a occult blood loss you may have to investigate. And there are rare forms of inherited conditions which are known as refractory iron deficiency anemia. So these patients have microcytic anemia, serum ferritin is low, you give iron, they don't respond. So there's definite iron deficiency, it's not a hemoglobinopathy, there's iron deficiency but very poor response. Can be iron refractory iron deficiency anemia, which are rare. Those are mostly molecular defects, genetic defects, which are being increasingly identified. These are new entities of iron absorption, transport and utilization. Diagnosis is extremely difficult in this country, usually requires genetic diagnosis. But if you want to treat, intravenous iron may be useful in some scenarios. Some of them will be on regular blood transfusions. That's iron refractory iron deficiency anemia. Another entity in pediatric practice is non-anemic iron deficiency. So as we learned, you have first develop iron deficiency, then when it is only severe and prolonged, you develop anemia. And people think there are consequences of iron deficiency in other organs apart from in the red blood cell. So there are claims that the iron deficiency per se, not anemia, will have neurodevelopmental adversities, maybe impaired psychomotor or mental development, attention deficit, low mathematical skills, so it's important in immunity. But still these are not 100% proven. Most people believe that they are there, but some people say it's not as bad as they were initially thinking. So there is an entity called non-anemic iron deficiency which will have some cognitive effect in the child. And some claim that even after treatment these are irreversible. But open for discussion, I am not also very convinced. Prevention of iron deficiency has been the sort of important topic in the preventive field and the WHO. So we need a dietary requirement that usually 1 milligram per day is needed to be absorbed. Normal diet, the bioavailability about 10%, so generally someone will require 7 to 10 milligrams per day. Bioavailability of iron is different in different foods. In breast milk it's about 50%, other formulae it's less. And it's higher in heme iron. Heme iron is the animal form of iron, which is about 30%, and non-heme iron 10%. So by having an iron-rich meal, you can prevent iron deficiency. And there's a movement for iron supplementation as well. Whether we need that is a question. The available evidence is supplementation, universal supplementation. That means giving iron prevention dose or supplementary dose to every child in this country and maybe in the world. It seems to be reducing iron deficiency, but we don't know the adversities of giving enough iron to a child who has normal amounts of iron. What's happening in the country at the moment is we are supplementing iron to a certain degree. We are neither there nor here. So there are two programs run by the Family Health Bureau. One is called multiple micronutrient supplementation, where babies are given sachets which contains iron and other micronutrients to be mixed with food and given for 2 months, at 6 months, 1 year and 18 months. It contains about 10 milligrams of elemental iron. But the problem with this is no one is taking. So it's being given. When you add that to the food, that makes a metallic taste, the children are refusing. So the sort of program that is meant to counteract micronutrient deficiencies seems to increase the macronutrient deficiencies, because they are now not eating even the food, the rice. So it's probably a failure in the part of our healthcare system. No one is taking it. And there is a movement, sort of the protocol or a guideline to give iron to school children during school medical inspection, which is happening at 1, 4 and 7 years. When they are at grade 1, 4 and 7, And the recommendation is to give them 1 tablet of ferrous sulfate, folic acid, vitamin C once a week for 6 months. Again, this has problem. It's not universally practiced, and I don't know whether it's useful to give it once a week, or because the absorption will be quite limited, and for 6 months. And the problem is, it's quite risky. So what they do is to give the entire pack to the child. And we had several kids, because they are being kids, they eat all the tablets in one go, maybe competition, and they come with iron overload and complications of iron toxicity, right? Not overload, iron toxicity, and they have to be admitted and given gastric or whatever the management of iron toxicity has to be done. So both these interventions have their own problems. So probably best would be to have iron-rich diet. 2 more slides on the differential diagnosis of microcytic anemia, because most of you might know my topic is thalassemia, that's my favorite. So, although the topic is iron deficiency, I need to tell you, not all microcytic anemia in this country or in children is due to iron deficiency. We did a small study of 104 children, who are diagnosed to have microcytic anemia, hemoglobin less than 11, MCV less than 70. And when we extensively investigated with ferritin, hemoglobin HbA1c, and genetic testing for alpha thalassemia, and only 49% of them had iron deficiency. 10% had beta thalassemia trait and 16% had alpha thalassemia trait. Alpha thalassemia trait is something which is not clinically significant in this country, but that's a well-known cause for microcytic anemia. And importantly, those 3 conditions are tend to coexist. So, there were 4 who had iron deficiency as well as beta thalassemia trait, and 3 with iron deficiency and alpha thalassemia trait. So, if you don't investigate, you might not pick them. So, being iron deficient will not make them not have alpha thalassemia or beta thalassemia. So how are we going to confirm the diagnosis of thalassemia trait? For completion, beta thalassemia trait can be easily confirmed by hemoglobin HbA1c, which are freely done in centers, designated thalassemia centers in the country. But the alpha thalassemia trait is difficult to diagnose unless you have genetic testing. So in summary, we know the prevalence of anemia in Sri Lankan children is 15%. Not all children with anemia in Sri Lanka has iron deficiency. However, the majority will have iron deficiency. Diagnosis, still we don't have a gold standard test, but the serum ferritin is the commonly used. Treatment, oral iron treatment, dose of iron. Parenteral iron or blood transfusions are rarely necessary. Thank you.
Thank you, Dr. Nityananda, for that nice overview on iron deficiency anemia in pregnancy. I would like to now invite all 3 speakers up on stage for a discussion on any questions.
Quite a small crowd we can see here.
Right, okay. Any questions to the speakers? Questions? Or are all your questions sufficiently answered by the comprehensive presentations?
I assume that's for me, the question.
Yes, mother is already diagnosed with a case of anemia closest to delivery. So, are we giving iron starting on the iron treatment for the baby?
No, generally not. Generally not. If you encounter a child less than 6 months having iron deficiency anemia, then you go back and see. But most of the time, the anemic mothers will deliver babies who have normal hemoglobin as well as normal iron. You don't have to investigate, neither treat. Purely based if the mother is on having iron anemia. But it's always good to investigate the mother. The mother may be having thalassemia trait. In that case, that is likely to be the case that maybe develops iron anemia, but the thalassemia trait again needs to be confirmed after 6 months, not before.
I know the current situation in the country for 2 seconds.
No, we are talking about delayed cord clamping.
The delayed cord.
Yeah, delayed cord clamping basically, if you, what is known is, if you delay the cord clamping for about 1 to 2 minutes, you send addition about 80 ml blood to the baby, and that helps to reduce the incidence of anemia. That's sure. And that is what the recommendation is, and that is what is practiced. Delayed cord.
Thank you very much for all the 3 lectures. I would like to ask, in a situation of sepsis, is it giving iron treatment at a condition of sepsis, is there a contraindication?
That's again, that has been the practice, not to give iron thinking that it will prevent the sepsis. But I haven't found anywhere, I haven't read conclusive evidence to support that. I don't know whether you have anything to add. Generally, if someone can argue why you don't give during this period and then restart. But I personally have been continuing. There's no evidence as such for me to conclusively say that giving iron treatment or our small treatment dose during infection is very harmful. But there are theoretical risks, which you all know.
Yeah, there's this theoretical thing. Why is hepcidin there? So in the infection and inflammation, hepcidin is secreted from the liver to stop the iron being absorbed, and the iron being mobilized from the macrophages into the hemopoietic system. And excess of iron in blood, absence of low iron in blood may theoretically reduce the bacterial division. So that's a theoretical thing. And there is this fear of iron supplementation in African children, universal iron supplementation in African children, that it could increase the malaria in sub-Saharan Africa if you give iron to them. Those are the only instances that I have heard. And of course, in our board, we don't give iron during the infection, not because we are afraid of sepsis. We don't give iron.
If a thalassemia trait child is having anemia, then what we can do for that condition?
So thalassemia trait children will, most of them will have microcytic anemia, some will not. But you need to demonstrate iron deficiency. If they are iron deficient, you do a serum ferritin. The serum ferritin is less than 15 or 12. They are also having thalassemia trait. On top of that, iron deficiency. That is, iron treatment is indicated. But if they are iron sufficient, no reason to give iron, even if they are anemic, because the anemia is purely because of beta thalassemia trait.
Can I just ask one question from Dr. Polisan? I think you suggested a very practical suggestion that if you find iron deficiency anemia in a adult, without going through all the investigations which are very costly, you can just start iron treatment and if there is lack of response or something like that, then to investigate further. Would you recommend doing at least serum ferritin in these patients, before starting iron, or with just full blood count, you can go ahead with your recommendation?
I think if a person is anemic, we have to make the diagnosis. Why is he anemic? I think the diagnosis of iron deficiency anemia is important. But treating the iron deficiency anemia and investigating for the cause of anemia is different. Say if your patient is if the patient is in the stage where there is increased iron need, say the children, the adolescents, the menstruating women and pregnant women, if they are iron deficient, you treat the iron deficiency and see whether they improve. But if your patient is in the at-risk age group of cancer, if there is iron deficiency anemia, I would extensively investigate that person, why that person is iron deficient. That is where we sort of cut off. If your clinical suspicion, if your patient is at risk of a cancer, causing bleeding. The other instance where we investigate is the patient has definite iron deficiency anemia and is not responding to iron. Then also we do investigate.
So what I'm saying is, if the patient is a pregnant child or somebody like that, then in that situation you can give a trial of iron. But otherwise, if it's elderly person and who can be having underlying malignancy or something like that,
You do the stool occult blood and the upper and lower GI endoscopies, and still, if you can't find the reason, there's a place for capsular video endoscopy.
And as you said, especially if you look at any guideline in management of anemia in pregnancy, even in the UK guidelines, that is what is recommended. If you have if you look at 1/3 of people are anemic, if you start doing serum ferritin in all these patients, and you will, the cost and the functions you will do on 1/3 of women unnecessarily. What is recommended is you treat with iron and see the response. You can see the response in 2 ways. Typically the hemoglobin level increase by about 0.8 grams per deciliter per week, and that's the usual rise, and or the rising retic count. You can assess, and if they are responding, you don't investigate further, treat them with iron, and then you can.
Yeah, may I add another thing? Say all of these full blood counts that we get, you have the red blood cell indices. If your patient has microcytic hypochromic anemia, I don't think that we should do the ferritin. But so we have a high percentage of thalassemia traits in the country. So to sort of rule out those, I would look at the red cell distribution width. The red cell distribution width, correct me if I am wrong, it's around normally 50. Yes, 30 to 50. If you have iron deficiency anemia, the patients will have the poikilocytosis, the different sizes and different shapes of red cells. So the red cell distribution will be more than 50. So it will be 17, 18, 20. So those patients you can, without any doubt, you can treat them with iron. But if your red cell distribution is with RDW is normal, I think those patients should be investigated for the possibility of thalassemia trait.
Any further questions? I think we had a good discussion as well. So let me thank the 3 speakers on behalf of the Sri Lanka Medical Association for their very comprehensive presentation, as well as clarifying all the questions that were raised during the discussion point. It is now my pleasure to invite them to receive the appreciation certificates and the lecture.